Picture the scene. It is 8 o'clock on a Friday morning.
Right, the classic Friday trauma meeting.
Exactly. You were sitting in the departmental trauma meeting. The coffee is entirely subpar as usual, and the next radiograph goes up on the screen.
And it's a distal radius fracture.
It is a distal radius fracture. Given that we see this injury every single day in the trauma clinic, you would assume the room would just nod in unison, agree on a management plan, and move on.
You would certainly hope so.
But no. Instead, half the room wants to put it in a cast. A quarter wants to use percutaneous K-wires, and the rest, well, they're already mentally opening the latest set of Volar locking plates.
Yes, the shiny titanium.
Right. It is a bread-and-butter clinical scenario, yet it remains this absolute battlefield of clinical opinion. So, for those of you in the trauma meeting, in the clinic, or prepping for theater, today's deep dive is designed to cut through that noise.
And there is a lot of noise. I mean, the sheer volume of literature is staggering.
It really is. We are looking at a formidable stack of clinical data today, ranging from the landmark Draft T and Draft T2 trials to the latest British Orthopedic Association standards for trauma, and even the foundational biomechanical papers of Jorge Orbe.
Essential reading for any trauma registrar.
Absolutely. Our objective is to unpack the current evidence base on when to operate, how to fix these injuries when surgery is genuinely indicated, and, crucially, what functional outcomes we can realistically promise our patients.
Which is often the hardest part of the conversation. The scene you just described, it's a universal experience in orthopedic departments globally.
It really is.
We are discussing an injury that accounts for nearly a fifth of all fractures treated in emergency departments.
A fifth. That is a massive operational burden.
Massive. And the sheer volume of these cases breeds this, dangerous familiarity, which often translates into institutional dogma overriding critical analysis of the trial data.
We just do what we've always done.
Exactly. For decades, the prevailing logic in orthopedic trauma was entirely morphological. The thought was, restore the anatomy to millimetric perfection, and perfect function will inevitably follow.
The carpenter's mindset.
Right, the carpenter's urge. But the evidence base over the last 15 years has forcefully demonstrated that the relationship between anatomical reduction and functional success is, it's nonlinear.
And in some patients, completely disconnected.
Precisely. In certain demographics, it is completely decoupled. So before we debate the merits of locking plates versus plaster casts, the clinical literature demands that we establish a precise anatomical and biomechanical understanding of the fracture pattern sitting right in front of us.
The language of the fracture. Because before deciding the surgical approach, we absolutely must define the injury.
You have to know what you're looking at.
But orthopedics has this notorious affinity for complex classification systems. We look at the literature, and it is an alphabet soup.
Oh, without a doubt.
We have the Freakman system, the Fernandez classification, and the exhaustively detailed AOTA alphanumeric system. But looking at this from the perspective of a busy trauma registrar on a night shift, are we treating the classification or are we treating the patient?
That is the ultimate question, isn't it?
All right. Does categorizing a fracture as a 23C2 versus a 23C3 actually alter the surgical approach on the ground? Or do the operative indications ultimately distill down to just preserving articular congruity?
Well, the clinical utility of these classifications varies wildly depending on whether you are conducting a meta-analysis or standing in the emergency department at 2 in the morning.
Right. Context is everything.
Exactly. The AOT system is unparalleled for research. It provides a highly granular morphological description. It differentiates between extra-articular, partial articular, and complete articular fractures.
And then subdivides them even further.
Yes, further subdivided by the degree of metaphyseal comminution. But you are entirely correct to question its immediate pragmatic value.
Because remembering it all is nearly impossible.
I mean, memorizing the 27 subcategories does not inherently tell a surgeon how to place their hardware.
No.
The Fernandez classification, by contrast, takes a distinctly biomechanical approach. It categorizes fractures based on the mechanism of injury and the specific energy vector that caused the bone to fail.
So instead of merely describing where the fracture lines are drawn on the X-ray, Fernandez forces the clinician to consider whether the bone failed under, say, bending, shearing, compression, or avulsion forces.
Which is infinitely more useful for preoperative planning.
How so? Give me an example.
Well, if the radiograph shows a classic Volar-Barton's fracture, Fernandez classifies this as a shearing injury.
Okay.
The clinical literature dictates that simple cast immobilization will almost certainly fail here. The inherent shear forces will just cause the carpus to translate proximally, and it drags the volar marginal fragment right along with it.
Because the anatomy naturally pulls it that way.
Exactly.
Yeah.
The mechanical solution is obvious. You must neutralize that shear force with a volar buttress plate. Conversely, a compression injury resulting in a central articular die punch fragment requires a completely different mechanical solution.
You can't just buttress that.
No, you often need articular elevation, bone grafting of the metaphyseal void to support it, and subchondral support. So the classification must dictate the biomechanical solution.
I see. So if we distill those biomechanical solutions down to the core clinical indications for surgery, we're generally looking at loss of reduction following closed manipulation, severe articular incongruity, and significant ulnar-sided instability.
Those are the big three, yes.
I want to focus on the radiographic parameters for a moment. Traditionally, there was an intense focus on restoring exact volar tilt, perfect radial height, and neutral ulnar variance.
The holy trinity of distal radius X-rays.
Exactly. However, current guidelines indicate that in younger, high-demand patients, those extra-articular measurements are actually secondary. The state of the articular surface itself is what dictates the long-term prognosis.
That's spot on. The native radiocarpal joint is extraordinarily unforgiving to intra-articular incongruity. It's a tight space.
Very tight. While gross angular deformities such as a severe loss of volar tilt will alter the kinematics of the midcarpal joint and decrease grip strength, a step or a gap in the articular surface directly alters the contact stresses on the cartilage itself.
It grinds the joint down.
Literally. Normally, the distal radius absorbs roughly 80% of the axial load across the wrist, with the lunate facet taking a significant portion of that stress.
Right.
Biomechanical data demonstrates that an articular step-off of just 2 millimeters, decreases the contact area of the radiocarpal joint by over 40%.
40% from a 2-millimeter step. That's astounding.
It is, and that concentrates the load, increasing peak contact stresses on the cartilage by upwards of 50%.
So the cartilage is taking a massive beating.
Exactly. In a high-demand, biologically active patient, leaving a 2-millimeter step is a definitive catalyst for rapid, symptomatic post-traumatic osteoarthritis. But measuring that step and gap accurately on standard plain radiographs is a known pitfall, isn't it? The distal radius is not a flat plateau.
Far from it.
The subchondral bone is biconcave. The radial inclination and the volar tilt of the lunate and scaphoid facets mean that a standard two-dimensional lateral or AP X-ray will consistently underestimate the true severity of the articular damage.
Almost every single time.
Especially with central die punch fragments, right?
Yes, plain radiographs are highly deceptive in this context. If there is any suspicion of an intra-articular fracture pattern, particularly involving the lunate facet or the sigmoid notch of the distal radial ulnar joint, computed tomography is mandatory.
You have to get a CT.
You must. A CT scan with fine sagittal and coronal reformats allows the surgeon to map the precise topography of the articular fragments. It differentiates between a step, which is a vertical discrepancy, and a gap, which is a horizontal separation.
And both are equally problematic.
Both parameters must be addressed. A gap allows the carpal bones to subside into the metaphysis over time, and that leads to secondary incongruity later on.
So the preoperative CT scan essentially dictates whether a standard volar approach is sufficient, or if fragment-specific fixation is required for a multifragmentary articular surface.
Exactly. It's the roadmap for the entire operation.
Which sets the stage for the primary controversy in this deep dive. Restoring articular congruity and maintaining stability are the undisputed drivers for operative intervention in younger patients.
Undisputed, yes.
For years, the unquestioned dogma was that open reduction and internal fixation with a volar locking plate was the absolute gold standard to achieve this.
It was what everyone was taught.
It offered rigid fixation, precise anatomical reduction, and the massive advantage of early mobilization. Then, the clinical literature, specifically the DRFT trials, challenged that entire paradigm.
Challenge is putting it mildly. The publication of the first EFT trial fundamentally altered the trajectory of upper limb trauma surgery in the UK.
It sent shockwaves through the community.
It really did. To appreciate its impact, you have to look at the clinical landscape of the early 2000s. The introduction of the volar locking plate was viewed as a panacea.
A miracle cure for the collapsing fracture.
Right. The ability to lock the screw head into the plate created a fixed-angle construct that did not rely on bone-to-plate friction.
Which is huge for poor bone quality.
Exactly. This allowed surgeons to hold osteoporotic metaphyseal bone rigidly, preventing the late collapse that plagued traditional compression plates.
So everyone started using them.
Consequently, the threshold for plating dropped dramatically. It became the default procedure, driven by the assumption that this superior biomechanical construct would inherently yield superior functional results for the patient.
But Professor Matt Costa and his team designed the DRAF-FT trial to test that exact assumption.
They did.
It was a rigorous, multi-center, randomized controlled trial, placing these highly engineered volar locking plates directly against closed reduction and percutaneous K-wire fixation.
A true head-to-head comparison. The inclusion criteria were specific adult patients with dorsally displaced fractures of the distal radius that could be reduced closed, but were deemed too unstable to hold in a cast.
So these were the fractures that historically demanded fixation.
Precisely. The primary outcome measure was the patient-rated wrist evaluation, the PRWE score, at 12 months post-injury.
And what did everyone expect the result to be?
Oh, the prevailing expectation among orthopedic surgeons was that the rigid fixation of the plates would demonstrate undeniable functional superiority over K-wires.
Because it just looks better mechanically.
Right. But the trial data showed absolutely no clinically important difference in the PRWE scores at 12 months between the two cohorts.
That finding was a tectonic shift. I mean, think about it. An implant costing hundreds of pounds, requiring a formal surgical approach, deep dissection through the flexor carpi radialis bed, and carrying inherent risks of hardware complications.
All of that.
And it was functionally matched at 1 year by a few percutaneous surgical wires.
It forced the trauma community to really confront the difference between radiographic superiority and functional necessity.
Which is a tough pill to swallow for surgeons.
It is. For fractures that can be anatomically reduced by closed manipulation and merely require temporary stabilization to prevent displacement during the healing cascade, the extreme rigidity of a locking plate just does not translate into a better functional outcome for the patient.
Because the wires are doing enough of the job.
Exactly. K-wires operate on the principle of intramedullary splinting. They hold the alignment just well enough for just long enough, allowing secondary bone healing via callus formation.
Well, the plates bypass that entirely.
Yes, the plates provide absolute stability and primary bone healing. But at 12 months, the patient's wrist function does not care which biological healing pathway was utilized.
Right, though the pushback from the surgical community often centers on the early recovery phase, doesn't it?
It does. That's the main counter-argument.
While the 12-month outcomes might be identical, volar plates allow the patient to abandon the cast and begin active mobilization within days of surgery.
Sometimes the very next day.
Whereas K-wires require the patient to remain in a cast or splint for 4 to 6 weeks. For a self-employed manual worker, that early return to basic function and independence might entirely justify the surgical risks and costs of the plate.
And that is a very valid clinical nuance. The DFT data did acknowledge a slight transient functional advantage for the plated group at the 6-week mark.
But it faded.
Yes, it equalized completely by 3 months. So the clinician must weigh that transient benefit against the complication profile.
Which isn't negligible for either option.
No, not at all. K-wires carry risks of pin site infections and require a secondary procedure for removal, albeit usually just pulling them in the outpatient clinic.
Right.
Plating carries the risks of profound tendon complications, which we will definitely explore later, and potential hardware removal operations down the line under general anesthesia.
So the evidence base provides the population-level data, but the clinician must apply it to the individual's socioeconomic and functional demands.
Precisely. It's shared decision-making.
So if DFT1 questioned the unquestioned dominance of the locking plate, DFT2 targeted an even deeper surgical instinct.
The urge to operate on a slipped fracture.
Yes, the absolute necessity of surgery for fractures that have lost position.
Yeah.
Let's dig into DFT2.
Right, so DFT2 evaluated adult patients with dorsally displaced distal radius fractures, but it specifically compared surgical fixation using either wires or plates against non-operative management in a cast.
And the critical detail here is the patient cohort.
Very critical. These were fractures that had already slipped or lost their initial reduction while in a cast.
And historically, a loss of reduction in the plaster room was an absolute, undisputed mandate for surgical intervention. You slip, you go to theater,
Always. You never accept a slip fracture. Yet the trial data revealed that even in this cohort of slipped fractures, patients managed non-operatively in a cast demonstrated functional outcomes at 12 months that were non-inferior to those who were taken to theater for fixation.
That is mind-bending. From a purely biomechanical standpoint, why do patients with unstable displacing fractures achieve such high functional scores without surgical correction?
Understand that we have to look closely at the demographic heavily represented in these trials.
EOLA patients.
Exactly. While DR-EFT included younger adults, the median age in these studies often reflects the bimodal distribution of distal radius fractures, leaning heavily towards the elderly osteoporotic population.
And their bones behave differently.
Completely differently. In this demographic, the rules of biomechanics and functional demand are completely distinct from those of a 25-year-old athlete.
Right.
When osteoporotic bone fractures, it does not just crack cleanly. The sparse cancellous trabeculae actually crust.
Like stepping on a honeycomb.
Exactly like that. This creates a profound metaphyseal void. So when the A&E doctor manipulates the wrist, they pull the bone out to length. But there is no structural scaffolding left inside to support the articular surface.
Oh, it's hollow.
It's hollow, so the bone inevitably settles back into a degree of deformity as the swelling goes down.
Which means we are routinely accepting radiographic malunion in this demographic. We are looking at radiographs of an 80-year-old at 6 weeks post-injury, showing 20 degrees of dorsal angulation, 5 millimeters of radial shortening, and completely altered radiocarpal alignment.
Frightening x-rays, really.
But the British Orthopedic Association standards for trauma explicitly support conservative management here.
They do, and those BOA standards are heavily informed by the paradox that radiographic malunion does not equate to functional failure in the low-demand elderly patient.
It's hard to reconcile what you see on the screen with the patient in front of you.
It is, but when you review that quote-unquote disastrous radiograph in the clinic, the patient often demonstrates excellent finger cascade, functional wrist extension, and reports minimal pain during their activities of daily living.
Why is that? Why doesn't it hurt them the way it would hurt me?
The senescent wrist adapts differently to altered kinematics. The ligaments are often more lax, allowing the carpus to accommodate that dorsal tilt without the severe impingement seen in younger, tighter wrists.
Ah, so they have more give.
Exactly. Furthermore, their peak load demands are low. They just do not require the precise articular contact mechanics necessary for heavy lifting or high-impact activities.
Translating that data into patient communication is arguably one of the hardest tasks in the trauma clinic. Patients are highly informed today, and they look directly at the monitors in the room.
They see the crooked bone?
Right. If an active 75-year-old sees a significantly angulated fracture on the screen, and the clinician advises against surgery, citing trial data, it can easily be misinterpreted as age-based rationing or clinical dismissal.
Oh, absolutely. They feel fobbed off.
How does the evidence-base guide that shared decision-making process without dismissing the patient's visual evidence?
It requires an honest, highly clinical pivot from morphology to biology.
Talk me through that.
Well, you validate the radiograph first. You confirm that, yes, the bone is angulated, but then you must explain the specific biological risks of operating on osteoporotic bone.
The risks being hardware failure.
Among others. You detail the high probability of screws cutting out of the soft bone, the increased risk of profound joint stiffness from the surgical trauma, and the potential for complex tendon ruptures.
Right.
You present conservative management not as a passive default, not just giving up, but as an active, evidence-based intervention designed to avoid iatrogenic harm while reliably achieving their ultimate goal.
Which is a painless hand capable of performing their specific daily tasks.
Exactly. The DRAF-FT2 data is the anchor for that conversation. It proves that exposing them to the risks of anesthesia and hardware does not statistically improve their outcome.
However, the pendulum cannot swing entirely to cast management. There is a definitive cohort where surgical intervention is absolutely unavoidable.
Oh, certainly. You can't cast everything.
Highly comminuted, displaced intra-articular fractures in biologically active patients or cases presenting with acute carpal tunnel syndrome demand operative fixation.
Without a doubt.
This brings us to the surgical masterclass. When the evidence base dictates a volar plate, the execution must be flawless. We have to discuss the biomechanical principles pioneered by Jorge Orbe.
Jorge Orbe's work fundamentally reversed the approach to distal radius fixation.
Reversed it entirely.
Historically, because the vast majority of these fractures displace dorsally,
Yeah.
the classic Hollis pattern surgeons intuitively attempted to apply plates to the dorsal surface of the radius.
Put the plate where the bone is sticking out.
Right, it makes logical sense. But the results were catastrophic.
Why?
Because the dorsal cortex is highly irregular, and the extensor tendons run in very tight compartments directly over the bone. Dorsal plates acted as mechanical abrasives.
Just sawing through the tendons.
Exactly, leading to severe tenosynovitis and widespread tendon ruptures. Orbe championed the volar approach, recognizing that the volar surface of the radius is relatively flat and possesses a much more generous soft tissue envelope.
And you have muscle coverage.
Crucially, yes. The pronator quadratus muscle can be elevated and subsequently used to shield the flexor tendons from the titanium implant.
Biomechanically, he utilized the volar fixed angle device not just as a simple buttress, but as a load-bearing strut. The locking screws capture the displaced dorsal fragments and cantilever them back into alignment,
It's an elegant engineering solution.
relying on the rigid plate against the volar cortex to resist the bending forces.
That cantilever principle is the sheer genius of the locking plate. It allows the surgeon to reduce complex dorsal comminution from a completely safe volar approach.
But there is a catch.
There is always a catch. This biomechanical advantage introduced a highly specific, devastating complication profile of its own.
Because you have to push the plate really far down to get those fragments.
Precisely. To capture those distal articular fragments, surgeons must push the plate as far distally as possible, and this brings the hardware into direct conflict with the flexor tendons.
Specifically at a critical anatomical juncture known as the watershed line. Let us define the watershed line precisely. It is often described conceptually in textbooks, but intraoperatively, it is a definitive bony landmark.
Anatomically, the watershed line is a transverse ridge located on the volar distal margin of the radius.
It's something you can actually feel.
Yes, you can palpate it. It represents the most distal limit of the pronator quadratus insertion and serves as the attachment point for the stout volar radiocarpal ligaments.
Why is it clinically vital?
Because the flexor pollicis longus, the FPL tendon, runs tightly over this exact ridge as it transitions from the forearm down into the carpal tunnel.
It bells right over it.
It does. During surgery, once you have elevated the pronator quadratus, you can sweep your finger distally along the flat volar cortex until you hit this prominent ridge just proximal to the joint line. That is your boundary.
The absolute rule in modern distal radius plating is that hardware must not sit distal to or proud of the watershed line.
It is a biomechanical non-negotiable. If the distal edge of the plate crosses the watershed line, it enters the functional space of the FPL tendon.
Even if you manage to repair the pronator quadratus over it.
Even then, and let's be honest, meticulously repairing that muscle over the plate is often biologically impossible due to trauma-induced tissue friability anyway.
It just turns to mush.
It does. So the plate will inevitably sit proud. And as the patient continually flexes and extends their thumb, the FPL tendon is bowstrung against the hard titanium edge of the plate.
And that leads to attrition.
This mechanical attrition is silent and progressive. Weeks or months later, the tendon simply gives way. The patient goes to pick up a kettle and the thumb just stops working.
Which presents a massive intraoperative dilemma. If you have a highly distal fracture line, such as a volar marginal rim avulsion, a standard volar plate positioned safely behind the watershed line simply cannot capture the fragment.
The screws will just sail right past it.
Exactly. They will miss it entirely. What do?
In that scenario, forcing a standard plate distally is, quite frankly, surgical malpractice. You must transition to fragment-specific fixation.
Using different hardware entirely.
Yes, you utilize low-profile hook plates that are designed specifically to sit flush against the volar rim.
They grab the lip of the bone.
Right, and they sit completely buried beneath the volar capsule, avoiding the FPL trajectory entirely. Alternatively, you might use buried wire constructs or even address specific dorsal ulnar fragments through a completely separate, dedicated dorsal incision.
So the key takeaway is that the surgeon must adapt the implant to the anatomy, not force the anatomy to accommodate a generic plate.
Never try to force the anatomy. The plate has to fit the fracture.
We must also address the outliers in the surgical armamentarium. The external fixator used to be the absolute default tool for complex intra-articular fractures.
It was on every trauma list in the 90s.
Operating on the principle of ligamentotaxis, applying longitudinal traction to the capsule and ligaments to literally pull the shattered articular fragments back into alignment.
Like pulling a Chinese finger trap.
Exactly. With the advent of multi-axial locking plates, does the X-fix still have a legitimate role?
Well, ligamentotaxis struggles to reduce central die punch fragments because they lack any soft tissue attachments to pull on.
They just float in the middle.
Right, which is exactly why locking plates largely superseded the X-fix for articular reconstruction. However, the external fixator remains an indispensable tool in damage control orthopedics.
In polytrauma.
Yes. In a polytraumatized patient who is hemodynamically unstable, you cannot justify a 2-hour open articular reconstruction of a wrist.
You have to save their life first.
Exactly. You apply a spanning external fixator in 15 minutes, neutralize the skeletal instability, and allow the general trauma team to address the life-threatening injuries.
What about open fractures?
That's the other main indication. In cases of severe open fractures with extensive soft tissue stripping or gross contamination, placing a bulky titanium plate into that hostile bed is just an invitation for deep infection and osteomyelitis.
It's a disaster waiting to happen.
The external fixator provides rigid skeletal stability while keeping the hardware far away from the zone of injury, allowing the plastic surgeons to manage the soft tissue defect safely.
Regardless of the hardware used, mastering the surgical technique is primarily about anticipating and mitigating complications.
Yeah.
We have discussed the volar complications, specifically the FPL rupture resulting from violating the watershed line.
The silent killer of the thumb.
But the dorsal complications are arguably more insidious, and they dominate the clinical literature regarding hardware failure.
The dorsal cortex of the distal radius is a high-risk zone, no question about it. When we talk about dorsal complications following volar plating, we're overwhelmingly talking about the extensor pollicis longus, the EPL tendon.
Right.
An EPL rupture is the signature soft tissue complication of a distal radius fracture. It can actually occur secondary to the fracture itself, particularly in undisplaced fractures.
Wait, undisplaced fractures rupture the tendon? How?
Yes, it's fascinating. The intact extensor retinaculum prevents the fracture hematoma from dissipating. This leads to increased pressure within the tightly constrained third dorsal compartment.
Like a compartment syndrome just for that one tendon.
Exactly. This causes local ischemia, tendon necrosis, and eventual rupture. But in the context of volar plating, an EPL rupture is explicitly iatrogenic.
Surgeon error. It comes down to screw length, doesn't it? When the surgeon drills from the volar surface into the dorsal fragments, measures the depth, and inserts a locking screw, a miscalculation of even 1 or 2 millimeters means the tip of that screw penetrates the dorsal cortex.
And penetrating the dorsal cortex in the region of the third dorsal compartment is catastrophic.
Walk us through the anatomy there.
The EPL tendon exits the third compartment, takes a sharp 45-degree turn around a bony prominence known as Lister's tubercle, and heads distally to the thumb.
So the tubercle acts as a pulley.
A mechanical pulley, yes. If a volar locking screw protrudes through the dorsal bone exactly at this pulley point, it sits directly in the path of the tendon.
That sounds incredibly painful.
It is. Every single time the patient extends their thumb, the EPL tendon is dragged under tension across the sharp threads of the titanium screw. It acts literally like a surgical saw.
Just fraying the tendon day by day.
The tendon frays, the patient experiences progressive pain, and eventually, the tendon snaps.
Detecting that prominent screw intraoperatively is notoriously difficult, though. If you take a standard straight lateral fluoroscopy view, the convex shape of the dorsal radius can easily mask a protruding screw.
It hides it completely.
The screw tip might appear to be safely buried within the bone on a 2D image, while in reality, it is sitting proud within the tendon compartment.
A standard lateral view is entirely insufficient to clear the dorsal cortex. The clinical literature dictates the use of a highly specific imaging technique, the dorsal horizon view.
Sometimes called the skyline view?
Yes, the skyline view. To achieve this, the surgeon does not simply shoot a lateral X-ray. You must drop the patient's hand into maximum volar flexion.
Bending the wrist right down.
Right. And then you tilt the fluoroscopy beam approximately 20 to 30 degrees so that it shoots tangentially across the dorsal surface of the radius.
Which profiles the bone perfectly.
It explicitly profiles the undulating dorsal cortex and sharply outlines Lister's tubercle. If you see even the faintest shadow of a screw tip breaking that skyline profile, it must be removed immediately and exchanged for a shorter screw.
No exception.
Leaving it is indefensible.
The clinical presentation of this complication is highly specific. When a patient returns to the clinic at 4 weeks post-op complaining of wrist pain, the clinician must differentiate between normal post-operative stiffness and impending tendon failure.
A high index of suspicion is mandatory here. Normal post-operative pain is typically diffuse, dull, and it improves with therapy.
What does hardware irritation feel like?
Hardware irritation is sharp, highly localized, and mechanical. If the patient points exactly to the dorsal aspect of the wrist, directly over Lister's tubercle, and reports a sharp catching sensation specifically when they actively extend their thumb against resistance,
That's the red flag.
you must assume the screw is irritating the EPL. This is not a watch and wait scenario. You must urgently organize an ultrasound scan.
Look for what specifically?
If the sonographer identifies active tenosynovitis, fluid around the tendon, or partial attrition from the hardware, those screws or sometimes the entire plate must be removed before the tendon fails.
Because once it fails,
Once the EPL ruptures, primary repair is usually impossible due to tendon retraction and poor tissue quality.
you can't just stitch it back together.
No, the patient requires a formal tendon transfer, typically harvesting the extensor indicis proprius, the EIP, to restore independent thumb extension.
Sacrificing an index finger tendon to fix the thumb.
Exactly. It is a major salvage operation resulting from a millimetric error in screw measurement.
Beyond the mechanical tendon issues, the distal radius fracture frequently triggers profound neurological and autonomic complications. Carpal tunnel syndrome is highly prevalent following this injury.
Extremely prevalent.
The displacement of the bone fragments, combined with the fracture hematoma and post-traumatic edema, dramatically increases the pressure within the anatomically confined space of the carpal tunnel, compressing the median nerve.
And the clinical guidelines are unambiguous regarding acute carpal tunnel syndrome in the presence of a distal radius fracture. It is a surgical emergency.
You don't mess around with it.
You don't. If a patient presents with dense numbness in the median nerve distribution and progressive thenar weakness, you cannot simply apply a cast and elevate the arm and hope for the best.
So what is the first step?
The primary intervention is an immediate anatomical reduction of the fracture in the emergency department to pull the bone fragments out of the canal and decrease the volume of the hematoma.
And if that doesn't work?
If the neurological symptoms do not resolve almost instantly following reduction, the patient must be taken to theater for a formal open carpal tunnel release alongside fracture fixation.
Because the clock is ticking on the nerve.
Exactly. Delaying this results in irreversible ischemic damage to the median nerve.
And finally, we must discuss the complication that haunts every hand surgeon and therapist complex regional pain syndrome, or CRPS.
The absolute nightmare scenario.
The fracture heals, the hardware is perfectly positioned, the radiograph is pristine, yet the patient presents with a swollen, shiny, profoundly stiff hand, experiencing excruciating pain entirely out of proportion to the clinical picture.
CRPS type 1 is a devastating multisystem autonomic dysfunction. The exact pathophysiology remains complex, involving an exaggerated neuroinflammatory response, sympathetic nervous system overdrive, and central nervous system sensitization.
It's the body's alarm system getting stuck on.
That's a great way to put it. It leads to severe vasomotor instability. The hand fluctuates between being red and hot to blue and freezing cold.
And the pain is unreal.
The hyperalgesia is so severe that even light touch, like a bedsheet resting on the skin, causes agonizing pain.
How do we stop it?
The key to managing CRPS is aggressive, early prevention, and immediate recognition. Tight, constrictive casts are a known trigger. Any patient complaining of unrelenting, burning pain under a cast must have it split to the skin immediately.
Don't just give them more painkillers.
No, free the soft tissues. Post-operatively, the single best defense against CRPS is early active digit mobilization. The hand therapist is as critical as the surgeon here.
What about vitamin C? That always comes up in the literature.
There is some debate in the literature regarding high-dose vitamin C supplementation as a prophylactic measure to modulate the inflammatory response.
Does it actually work?
Well, the data is somewhat mixed, but the risk profile of vitamin C is negligible, and it is frequently employed in trauma units as a cheap, safe adjunct. But honestly, nothing replaces early recognition and immediate, aggressive, multimodal pain management and therapy.
We have navigated an immense volume of clinical data today. We have moved from the microscopic contact mechanics of the articular surface to the macroeconomic shifts in national treatment guidelines driven by the DIFT trials.
It's a lot to process for anyone.
It is. For the clinician heading into their next trauma meeting or preparing to consent a patient in the emergency department, let us distill this deep dive into the absolute core actionable takeaways.
I would anchor clinical practice to three definitive principles based on the current evidence. First, regarding the osteoporotic patient radiographic malunion is not synonymous with functional failure.
Treat the patient, not the x-ray.
Exactly. The DIFT2 data and BOA guidelines emphatically support conservative management for these fractures, even when displaced. Do not operate on an X-ray, operate on the patient's functional demand.
Excellent. And the second?
Second, when executing a Volar approach, respect the watershed line. It is the absolute distal boundary for Volar hardware.
Otherwise, the thumb pays the price.
It does. If you place a plate distal to that ridge, you are virtually guaranteeing an FPL tendon rupture down the line. Use fragment-specific fixation if the fracture dictates it.
And the third principle.
Third, regarding the dorsal cortex, always check the dorsal horizon. A prominent dorsal screw is a mechanical guillotine for the EPL tendon.
Use the skyline view.
Utilizing that skyline fluoroscopy view intraoperatively is a non-negotiable step in confirming hardware safety.
If you found today's deep dive valuable for your clinical practice, please take a moment to rate and share the program with your colleagues so we can keep bringing you these high-yield discussions.
Thank you for having me.
To close, I want to leave you with a lingering thought that pushes beyond our current clinical horizons. We've spent an hour dissecting the precise nuances of titanium plates, wire trajectories, and the limitations of plaster casts. But orthopedic trauma is standing on the precipice of a new era. With the rapid advancements in biologic augmentation utilizing osteoinductive proteins and targeted growth factors to drastically accelerate the physiological healing cascade and the emergence of 3D-printed patient-specific implants designed to perfectly match the unique topography of the fractured bone, we have to wonder about the future of this debate. Will these intense controversies over the watershed line and screw lengths eventually become obsolete relics of generic hardware? Or will the fundamental disruptive lessons of the DRFT trials, the quiet, evidence-based realization that less surgical interference is often functionally superior, stand the ultimate test of time?